Hello and welcome to our educational package on respiratory distress and failure. Moving right along, health services across Manitoba are provided in facilities located on the original lands of the First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This whole presentation is intended to be general information to broaden the knowledge base and inform practice of paramedics across shared health. The whole idea here is that this presentation will allow you to take this knowledge and move forward with any iteration or variation or updates on patient care maps as they may come. We're not teaching to the care maps anymore. We're providing information that will allow you to adapt to any care map as it updates. So, to talk about respiratory failure, there are four types, as we kind of see from the four squares here. So when we look at respiratory failure, right, the first type that we come to is hypoxic respiratory failure. Okay, so causes of your hypoxic or hypoxemic respiratory failure. First one being simple altitude. The higher we go, the rarer the air, right? The less oxygen content in the air at altitude. Okay, so just as an example. Okay, other things to think of, we've got our medical disorders or we've got things like overdose, right? So if a patient has a seizure or a stroke, some kind of overdose, something that is interfering with the patient's ability to effectively breathe in, right? They can't take oxygen in, we become hypoxic. The next one that we want to think about potentially is the shunt physiology. So we've got a section of lung that either has perfusion, right? There's blood flow to it, but there's no oxygenation. Air can't get into the alveolar bed, so there is no gas exchange. The other is that we have a perfusion deficit, but air is getting down. So we've got air in the alveolar space, but we don't have the availability of the blood in the capillary beds to actually pick up oxygen and exchange carbon dioxide out. So that is how we develop a shunt of one form or another. We got airflow or a blood flow problem. We're starting to get into our more typical presentations, things that we think of. So this is you have your burn patients or your chemical inhalations, right? Something has happened to the airway or to the alveolar beds that has caused damage that is preventing air and carbon dioxide from exchanging effectively. To our really typical kind of presentation. Right. We've got your CHF or your heart failure patient, your pneumonias. There is something physical in the lungs, fluid, mucus, pus, whatever the case might be. There's something in the lungs that is preventing oxygen from reaching those alveolar beds effectively and is reducing the ability for oxygen to get into circulation. So we have a hypoxic failure. So when we look at a hypoxic respiratory failure patient, right, a type 1 respiratory failure patient, it really depends on their presentation as to how severe they may be. And for this, we kind of come back to the oxyhemoglobin dissociation curve, right? This thing we thought we would go to school for, forget all about, never have to look at again. Surprise! It actually matters here. Okay. So in our type 1 failure patients, right, they're having a problem getting oxygen in, not necessarily getting air out. So when we look at our patients overall, right, we have a little bit of an oxygen deficit. Their CO2 may be normal or perhaps a little bit low, okay? So the more hypoxic we get, right, the faster we kind of breathe. Our brain goes like, I need more air. Just like if your heart gets into distress, we need more perfusion, more blood flow, right? The brain will say, heart beat faster. It tells us to breathe faster if we start to get a little hypoxic. And with that, the faster we breathe, the more CO2 we offload. So even though there's a bit of an oxygen deficit, we're still effectively exchanging carbon dioxide out. Where we have to watch is when it becomes severe, when we have a hypoxic or when we have a degree of hypoxia and hypercapnia. The patient is now failing in both directions. This is respiratory failure. We get to the right side of the oxyhemoglobin dissociation curve, and we're moving into respiratory failure. we're going to have to be much more aggressive in managing this airway up to and including ventilating our patient. Right. Our type 2 respiratory failure are our hypercapnic patients. These are air trappers. So what we typically think of, right, are COPD, bronchitis, emphysema, asthma, or other restrictive airway diseases. Okay. There are a few others here that we'll get into as we go along. So, but in that typical kind of presentation, right, we have our normal airway on the left. In an asthmatic or a chronic bronchitis kind of airway, we always have a degree of inflammation. There's always some varying degree of inflammation going on that is restricting some airflow. But when it becomes, when we have an acute exacerbation, right, those smooth muscles, right, those muscle walls thicken, they constrict down, narrow the airways, right? And as things get tight, that's how we air trap. We take a deep breath, right? We create negative pressure, those airways open a little, air gets in, but as soon as we relieve that negative pressure, those airways snap back closed and are very tight, and that's how we get that wheezy airflow and that prolonged expiratory phase, right? Takes our patient a little while to get that air out, right? It's not always just a physiologic thing. Sometimes it's things that we do. Collars and boards are not benign interventions. These things cause airway restriction. They cause increased intracranial pressure. They put us in non-physiologic positions that can be very difficult to breathe in. Right? We can make it difficult for a patient to effectively exhale. Okay. Just like we had in type 1, we also can deal with drug overdoses or medication errors here, anything that's causing us to ineffectively exchange gases. It just depends on whether we see the hypercapnic side or the hypoxic side first. Okay. Now, peripheral nerve diseases or neuromuscular diseases. Okay, these are a whole range of disease processes that will eventually lead to difficulties in nervous transmission and controlling normal respiratory function. So in muscular dystrophies, right, we have myotonic musculodystrophy or like Duchenne's muscular dystrophies. Not diving down into each of these, this is just quick examples, okay? Hey, so we have polymyositis, neuroautoimmune disorders, right? Muscular phosphorylase deficiencies. We can have epilepsy, Parkinson's disease, ALS, right? Myasthenia gravis. When we talk about peripheral nerve disease, generally we're talking trauma, though there are other medical causes in there. If you want to dive down that rabbit hole, I would encourage you to. There's a whole range of things that can cause problems with muscular control of respiratory function. Other things you can think of would be like epilepsy. Oh, wait, sorry, we already spoke to that. Derp, my bad. Okay, but either way, we end up back to the oxyhemoglobin dissociation curve. So thinking that these are our air trapper patients, right? These are the patients you see doing the pursed lip breathing, trying to catch their breath. They're essentially trying to recruit more airspace in their lungs, more alveolar beds, and allow for a prolonged expiratory phase to get the CO2 out. So because these patients are air trapping, they generally don't have problems getting air in, but they have problems getting carbon dioxide out. We can have normal to low oxygen levels, but we will have a higher concentration of carbon dioxide, right? So we put our patient on end tidal, we will see retained CO2. Okay? Still, when we get into that severe patient, we're hypoxic and hypercapnic. We're still moving to the right side of the dissociation curve there and getting into respiratory failure. So this gives us some warning, right? If we start to see the end tidal going up further and the SATs decreasing despite our interventions, patients getting bad, we're going to have to do airway things. We're going to have to, be a paramedic today. Type 3 respiratory failure. Hypoxic failure, but it's post-surgical. Kind of an extension to type 1, the difference being we caused it. Right. So this patient, just had an open abdomen or their chest is open, right? They've had a full sternotomy, something like that. Okay. They have difficulty or get a little bit hypoxic because they're not able to necessarily take a full deep breath and really expand their chest or their abdomen because it hurts. The surgical scar or the surgical site is still healing, right? So they have restricted air movement. Most of these patients take a couple liters of oxygen by nasally and, problem solved. We're done. Right? It's usually a very, very simple fix, but just realize what the likely culprit is here. Okay. The last one, type 4 respiratory failure, it's actually secondary to shock or a hypoperfusion state. So there's not necessarily a problem getting air in or out of the lungs, but there's a problem circulating both oxygen and carbon dioxide. So we fix whatever's interfering with perfusion, we fix the respiratory cause, right? So in distributive shock, our common ones being sepsis and anaphylaxis, right? We have a fluid shift issue. Add some fluids, improve perfusion, the patient gets better. If we think our obstructive shock presentation, so we've got embolus or thrombus, right? You can have a STEMI, you can have a PE. There's something in the way. Okay, hypovolemic, right? So patients have bled out or they're dehydrated, they need some volume repletion. Keep in mind trauma standards if we're looking at exsanguination, right? We're still trying to work hand in hand there. And then cardiogenic. Keep in mind that the vast majority of cardiogenic shock presentations start with an MI, right? MI can lead to heart failure, right? Hypertension can also cause things, but the vast majority of cardiogenic shock presentations start with an MI. It's over 80%, right? So fix the perfusion. That fixes the respiratory side of things. We improve the ability of the body to circulate oxygen. So how do we come to the clinical diagnosis or that differential? First, a lot of these cases, right, are based around the history and physical. Take a very good history of your patient. Okay? And historically speaking, we're not the best at this. We obtain a sample history and quite often fail to go much further. Take that history and put it into clinical context of the patient in front of you with the rest of your exam and the rest of your diagnostics. We do have to come to some kind of diagnostic or field diagnoses to actually treat effectively a condition, right? Otherwise, we're shooting in the dark and hoping for the best, and that's kind of sloppy medicine. Okay, so what do the patient's lungs tell us? Are they clear? Do we hear other kind of adventitious sounds? Is there something off sounding about the heart if you're familiar with those sounds? Does the patient's presentation correlate with the vital signs? Right? What does their end title tell us? We all have the availability of end title on truck. It's on all of the monitors that have been purchased by the province. We just need to have the appropriate equipment to tap into and read it. So whether we're looking at the passive nasal monitoring, which can also deliver oxygen, or whether we're a little more invasive and it's an inline reader. So whether it's BVM or the tube, either way, end title's a tool that we can use. 12 leads, have a low threshold to grab a 12 lead, right? Think of it this, if you've got enough to poke a finger and check somebody's sugar, you got enough to grab a 12 lead, right? If you're thinking that you should just put your regular monitor on, well, and get a rhythm strip, throw 6 more stickers on your patient and grab a 12 lead. It's low hanging fruit. It's an incredibly non-invasive thing to do. Okay, and it can yield great results. If nothing else, it can tell us that there isn't something happening that we can see at this point in the heart. Okay, now end title at a glance, because we've been talking to this a little bit. Normal range, 35 to 45 millimeters mercury with a euboxic waveform. That's what we're seeing right here. We have a nice upslope, right? That plateau phase, our end tidal peak, and a quick drop off. Okay, what that reading should be right between 35 and 45 millimeters mercury under normal conditions. Okay, now the shark fin. What does this mean? It's bronchospasm. It's absolutely bronchospasm. It means that we have air trapping. Okay, and it can still be absolutely in that normal range, just depending on the severity of the patient, or it can be high. It can be above, depending on how much air or how much trapping that patient has going on, how much restriction they have in the lungs. Okay, a reverse slope. Their end tidal can be anything, but this is diagnostic of emphysema. These patients have lost all the elasticity in the alveolar beds, and so what's going on here with the reverse slope is showing that expiration or exhalation is an active phase, right? The patient is forcing their air out. They're constricting their muscles to get air out of their lungs, which is why we have a very hard upslope with a negative plateau phase. Pardon me. And then we can have hypercapnia, anything above 45 millimeters. Usually this is associated with hypoventilation, right? A patient who's breathing slow. So we have to look at the clinical correlation with what's going on. Do you have somebody who's overdosed? They're breathing at a rate of 6 and their end tidal is 50. We can fix that very easily. You bag them. Right? And then we can consider potential pharmacologic aid depending on the cause of the slow respiratory rate. Words escape me there, I'm sorry. Then we can look at hypocapnia, right? So an end tidal less than 35 millimeters mercury, typically associated with hyperventilation, right? So this can be from a whole range of causes. So is the hyperventilation state, is it appropriate to your patient's condition? Do you have somebody breathing away at a rate of, 50 with a DKA and their end tidal is, 10? Okay, they're breathing faster, they're breathing deep, they've got that Kussmaul's kind of respiration. I'm expecting a low end tidal. If I had rapid respirations and a high end tidal, I'd be concerned that patient's not moving gas effectively and they're going into respiratory failure. If that respiratory pattern starts to round off, right, this is a patient that's fatiguing out. They're getting tired and they're about to go into failure and they're going to require assisted ventilations. Right? If not outright failure. We have a whole presentation coming on capnography here, so I don't want to steal too much thunder. Just realize that it is a very useful tool, and we can't speak enough of it. Okay. So what do we do to fix respiratory failure in typical forms? Right? Well, don't forget the basics. Oxygen. Is your patient hypoxic at all? Are they short of breath and require a little bit of oxygen assistance? This completely depends patient by patient, right, as to whether this is an appropriate tool or not. And we can look at it anywhere from our nasal cannula all the way up to non-rebreathe face masks. We can deliver CPAP or BiPAP potentially, right? That's a tool back in the toolbox. Non-invasive ventilation to assist our patients, as well as bag mask ventilation if required, right? Where that's authorized again. Now, enhancing bag mask ventilation and perfusion, your PEEP valve is a game changer. So I would encourage everybody to have a real good look at PEEP and see what it does for us. We're going to touch on it briefly here, but you can have a much better look at this on your own and understand the benefits of PEEP. Even if you just check out a couple of YouTube videos, you will see some very practical examples there. It is a wonderful tool and it is a game changer when we get into artificial or rescue ventilation for our patients. Okay, helps us recruit more lung space, as we see here, right? So as we increase the level of PEEP in patients that we're ventilating, we are decreasing the amount of dead space that we have in patients' lungs. Okay, PEEP is a wonderful tool. It's allowing us to recruit more alveolar beds and to more effectively ventilate our patients. So PEEP, under normal circumstances, we all have a degree of PEEP. Generally in our lungs, we're sitting somewhere between -1 and -3 centimeters of water. And that is what, along with surfactant, keeps our alveolar beds open so that we can just breathe normally, right, unaided, without any degree of distress. It's what's stopping us from having to go every breath to pop things open. Now we get into auto PEEP. This is where our patients have a degree of restriction, right? So they are CO2 retaining, they're air trapping, they're having trouble getting things out. We can use an extrinsic source of PEEP, like a PEEP valve or CPAP, right, to create an artificial level of PEEP within the thoracic cavity or within the lungs, and to allow, as long as it's below that level of auto PEEP, right, to allow those trapped gases out and to let our patients have a more effective expiratory phase. We can also use this to recruit more lung space in patients who are not utilizing their lungs effectively. They're breathing too shallow, right? So we can use it in both type 1 and type 2 patients. Other tools, right? Bronchodilators. Ventolin, right? It's our short-acting beta-2 agonist, right? Causes smooth muscle relaxation within the lungs themselves. Atrovent is a little bit different. Atrovent works on our parasympathetic side by targeting M3 or muscarinic 3 receptors within the lungs. We don't carry Atrovent itself. What we do have is Combivent, which is both salbutamol and ipratropium, or Atrovent, put together in one inhaler. Okay. So what do these things do? Right, so the easy stuff, right, our salbutamol stimulates our beta-2 receptors, sympathetic agonism, which results in bronchodilation. It works because when we stimulate the beta-2 cells, what it ends up doing is stops the calcium efflux from the smooth muscle in the lungs. And when we stop the movement of calcium there, we cause all those myosin actin fibers to relax, which then results in that smooth muscle dilation. The parasympathetic side of things, so this is where Atrovent or ipratropium bromide comes in, we stimulate those muscarinic 3 receptors. So normally, the stimulation of the M3 receptor causes parasympathetic agonism. And the parasympathetic side of our nervous system actually stimulates bronchoconstriction because we're at rest. We don't need that big dilation so that we can, utilize our lungs effectively to exchange oxygen and carbon dioxide as we're, running and we're in that fight or flight kind of thing. So ipratropium bromide or Atrovent, right, inhibits or antagonizes our M3 receptors. When we cause that antagonism, we block the parasympathetic side of things, which then results in bronchodilation because we're inhibiting stimulus that would cause bronchoconstriction. Further down the road, because M3 is tied into that parasympathetic side of things, it causes acetylcholine inhibition. And what that ends up doing is, as we block acetylcholine, we inhibit secretions, we dry things up. So epinephrine, how does this help us now within our respiratory distress patients? It depends on the presentation. Okay? But epinephrine is a very useful tool for us. You can kind of think of epinephrine as the tool in the toolbox when the inhaled agents have failed, right? Our patient is not responding to inhaled agents or they're not responding well to it. You can consider epi. Okay? Epi we'll get into it, but does stimulate bronchodilation. It is also back available for us now in the nebulized or inhaled format for croup. Okay. The reason this is back, just a little side note, is there has not been in the case literature a single case of croup that has been associated with COVID-19 for children. Okay. So it is a safe treatment here. To my knowledge at this point, this is the only nebulized medication that we will have back at present. Okay. Now, how does epinephrine work for us? Huge systemic effects. So whether we're looking at our bronchoconstriction kind of patients or whether we're looking at anaphylaxis, right, this is kind of a one-stop shop for us. So on the alpha-1 side of things, if required, in your anaphylaxis sort of presentation, right, it increases or encourages vasoconstriction and increases peripheral vascular resistance, decreasing mucosal edema. So the vasoconstriction and vascular resistance stops capillary leak in our anaphylaxis kind of patients. It stops that third spacing of fluids. Right, decreasing mucosal edema from alpha-1 stimulation, that happens in the lungs. It stops the secretions of things. Alpha-2, we intentionally left blank. It doesn't have anything to do with respiratory function at all. It's almost purely cardiac. If you want to look that up, feel free to do so. When we hit the beta-1 side of things, we increase chronotropy and inotropy, right? So we make our heartbeat stronger and faster. Okay. And improve cardiac output, very beneficial in our anaphylaxis patients. Okay, beta-2 receptors increase bronchodilation and decrease mediator release. It helps to re-regulate histamine, basophils, the macrophages, things like that. Anything that is going to mediate histamine response helps to bring back in. This is why epi is your one-stop shop in anaphylaxis, because it actually has those systemic effects, right? And it hits all the big spots that we need. The bronchodilation is where we get benefit in patients who have bronchoconstriction that's refractory to our inhaled agents. right? So, coming in the front door isn't working, so we send somebody in the back door essentially to try another way. That's what's going on here. Keep in mind there is very little, if any, benefit to administering both inhaled agents and bronchodilate, or our inhaled agents and epinephrine, right, injectable together. They have equal efficacy. So we kind of consider epi if inhaled has failed or the patient is not responding well to it at all, right? Then you can double up. What we would typically encourage is that you use the injectable until the patient starts to improve and they start to show more response to the inhaled agents, and then switch back to our inhaled bronchodilators, whatever's appropriate. Okay. Now, steroids, not in all of our indications. It does sit in asthma, or sorry, not asthma, sorry, anaphylaxis at this time. But it plays a downstream role really in any kind of respiratory distress that has an inflammatory change or influence to it. Okay, so what ends up happening is a steroid is administered, hits the receptor sites, and then it activates all of these anti-inflammatory systems, right? Everything that kind of suppresses inflammation, it activates. On the flip side of things, it also represses all of the mechanisms by which inflammation would be stimulated, right? So we have activation of the good stuff, repression of the bad stuff. Steroids are not the lifesaver, right? Very few patients outside of adrenal crises have been saved from a steroid, if any. The steroid is something that helps us 4 to 6 hours down the road, because these medications have one heck of a chain that they have to go through before we actually start to get the systemic effects that we want. We have some pretty decent evidence that signals that these are beneficial to patients, but we don't have anything that tells us that this is the make or break. However, the sooner we get these medications into our patients, the less time they potentially have to wait in ER to make sure that the patient isn't going to have a refractory event, which is really what we're trying to do with steroids. We are trying to prevent the patient from having a biphasic event where they seem to get better and then shortly, or not shortly, but several hours down the road, they have another asthma attack. They have a relapse of their anaphylaxis, whatever the case might be. Okay, so depending on your transport time and where you are, it may very well be worth calling OLMS and having a discussion about administration of steroids. Magnesium sulfate. No, this is not on any standing order list right now. This is a discussion with OLMS at present. But magnesium sulfate is a very potent smooth muscle relaxant and bronchodilator. So what ends up happening is at the muscular junctions, in this case for mag sulfate, right, we end up inhibiting the calcium channels. And when when magnesium inhibits those calcium channels, closes those calcium channels, again, it stops the myosin-actin fibers from maintaining constriction because they no longer have that stimulus from the calcium, and it relaxes the smooth muscle. It also inhibits acetylcholine, right? And inhibiting acetylcholine further suppresses the parasympathetic side of things. Parasympathetic suppression leads to better bronchodilation and response to beta-2 agonists, right? So it can be very, very beneficial in patients that are refractory to beta-2 agonists. Nitro, right? Not all respiratory distress is stimulated from bronchoconstriction. We have our CHF, our pulmonary edema kind of patients. Nitro is our #1 go-to for the majority of these patients because we have a fluid shift issue. You look at our CHFer, the vast majority of them are hypertensive, right? And they are peripherally constricted down, causing increased systemic vascular resistance, which is putting strain on circulation or pulmonary circulation on the LV, which causes that backup, and we get that fluid shift. So what we need to do is open up the peripheral vasculature and give that fluid somewhere else to be. We want to lower our afterload. Right? And by lowering the afterload, as that clears off, we then reduce preload and reduce the stressors on the patient. Okay. How does nitro work for us? Essentially, it gets synthesized over into nitric oxide, which in downstream effects, right, inhibits calcium, which then again, if we block calcium or inhibit calcium influx and efflux, we cause all those smooth muscle fibers to relax, which then dilates blood vessels, dilates the pulmonary vasculature, works very, very well. Okay. So in low doses of nitro, right, we increase the capacitance of our venous side and the blood vessels, right? And dilation of a lot of those things reduces myocardial oxygen demand, reduces the afterload, which then has effect on the preload. In higher doses, we can have direct effect on the afterload by dropping arterial pressures. So that's generally IV nitrates. When we're talking lower dose, we're talking our transdermal and our sublingual nitrates. We do have some effect on our direct effect on afterload myocardial oxygen demand of the coronary arteries, but it is much more predominantly effective in the venous and pulmonary side of things. Lasix, one of the most contentious drugs that we carry. Okay. Lasix is a very potent diuretic, works in the thick ascending loop of Henle here. And what Lasix ends up doing is preventing the resorption of sodium, right? So instead of coming back into circulation, right, up to 25% of filtered sodium ends up down in the bladder, right? And where salt goes, water flows. So it ends up pulling a big water content, it ends up pulling a big content of water volume from the patient with it down into the bladder where it's diuresed out. Where we get into trouble sometimes with Lasix is that, one, it is not a potassium or other electrolyte sparing agent. So with salt comes potassium, chloride, calcium, anything else that happens to be in circulation in roughly equal doses or equal parts. But at the same token, it is also it's contentious for us in that a lot of the patients that we treat for heart failure or pulmonary edema, anything like that, they're not actually fluid overloaded. They have a fluid shift. So before you administer Lasix to a patient, you want to look and assess and see if they're actually fluid overloaded. If they don't have a degree of fluid overload, we can cause more harm with, we can cause actually a lot of harm with Lasix because we're further dehydrating the patient, and we may actually end up making them worse because we're taking somebody who has a fluid shift issue because they're dehydrated and further adding to that, pardon me, dehydration by causing them to diurese more fluid out. Bad stuff, right? Not good for our patients. So before you think of Lasix, have a really good assessment of your patient and see if they actually show signs and symptoms of systemic fluid overload. Not worried about a little bit of dependent edema in the feet, the ankles, maybe even the lower calves. I want to see systemic. I want to see that creeping up. I want to see fluid retention in the belly. I want to see, like a fluid wave there. I want to see other signs of peripheral edema. I'm looking to see, right, overall how my patient appears. Are they diaphoretic all over? Are they does their watch band or their lifeline band or whatever, does that cut into their wrist? Has that left impressions because they have so much fluid on board? I want to see systemic signs of fluid overload. Otherwise, I can really cause harm. Okay. So in short, right, we prevent the reabsorption of sodium, which causes water excretion. That's kind of how we look at our shortness of breath, respiratory distress patients, right? So if there are any questions, please don't hesitate to reach out to a member of the provincial education team. We'd be happy to have further discussions with you around these topics and subjects, clear up any questions. I've fielded several already regarding Lasix specifically, but please reach out and we're happy to help. Thank you very much for your time and attention.